So we're going to present in English, and first I'd like to congratulate the organizers, Felipe, Fred, for this great meeting. It's always great to update our knowledge with this great group of specialists. It's easy to define a traditional single and a large brain tumor like this one. We have this new trend of treatment or current trend of treatment. You can perform a preoperative radiosurgery followed by surgery and en bloc resection. That's easy. So I'm gonna present a difficult case, not this one, a real world case. Imagine a male, 51 years old. In 2016, he underwent for a surgery for a dorsal lesion, and it was a melanoma. He has mutated with no systemic disease, and the option at that time was just follow this patient with no adjunct treatment. The first question that we should do for the oncologist is, and I kindly ask to Dr. Baldotto to answer, for this new oncology patient with a melanoma, when should we require an upfront brain MRI for all patients, or only if he presents any kind of symptoms?
Hi, good evening, everyone. Thank you for the invitation. Marcus, since you have a very high instance of brain mets, and now we have different types of treatment with good prognosis for these patients, I usually order MRI for all patients with stage 4 disease, and also for patients that have like stage 3 disease. And sometimes I think about even when they have initial disease, because we have a lot of different decisions to take when we have brain mets. It's different from the past when we didn't have too much to give for these patients.
Okay, thank you. The patient was fine until 2019. He started to present headaches, one episode of a sudden tremor and a left hemiparesis lasting 3 minutes that maybe seems to be a seizure. And then he performed an MRI and a PET scan that I'm going to present. But before that, as usual, this is the emergency room protocol, stand of system protocol. He started an anti-epileptic drug and steroids. He started his first assessment based on that. The question that I would like to make to Dr. Hussain, I wonder if Dr. Hussain is still there. We wonder for gliomas patients, we used to discuss a lot the benefits of valproato and valproic acid and levetiracetam, maybe for survival, trying to avoid the enzymatic induction drugs like phenytoin. Do you have a best anti-epileptic drug for brain mets patient? If Dr.
Yes. Yeah, I actually thank you for the question, for the very interesting case. You know, first of all, I'll tell you, with BRAF and MEK inhibitor, there was a cohort on that COMBI-MB trial that were on levetiracetam, and they didn't have any interaction with the dabrafenib trametinib from a PK/PD perspective. But I will actually ask Dr. O'Brien if she's still on, because she is our resident expert on anti-epileptic therapy for those patients, and she has some thoughts about the use of those in prophylactic as well, prophylactically. Barbara, are you still on?
Sure, I am here. Yes, we use levetiracetam, and the reason is that it's so well tolerated, and it doesn't interact with other medications, and we don't have to deal with the CYP issues of some of the other drugs. It doesn't tend to affect the blood counts, and it just, as I said, it's generally well tolerated and effective. Sometimes we do have to deal with the side effects of fatigue, which is present in many of the anti-epileptics. And for some patients, they do develop some irritability, which often improves with time, but not always.
Okay, great. And Dr. Battistella, do you agree? Do you have any additional comment?
I agree with Dr. O'Brien. Hi, thanks for the invitation. I usually use the new generations of anti-epileptic drugs like levetiracetam, lacosamide, and lamotrigine. It's better because of the the aspect of not having an interactions, just like Dr. O'Brien said. But I do also would like to remember that if we have to use the other anti-epileptic drugs, they should also be effective, but we might have to deal with some side effects that commonly we do not see with levetiracetam, for example. Unfortunately, not even levetiracetam nor valproate showed some benefits in overall survival for our patients, mainly glioma patients, like you said, Maldon. Thank you.
Okay, thank you. So it's interesting that 100% of our panelists just agree to use levetiracetam as our first choice. So let's keep moving. Okay. So this is the PET scan that we can see some disease, lung disease, a liver disease, and some spots of a brain disease as well. So we have a disseminated disease in several organs. And the question that we used to do is, how useful is PET scan for brain met screening? Because we know that this is a routine in the oncology field, and of course, in a patient with a symptomatic neurological symptoms and brain disease, it's easy to order an MRI. But can we expect any help or any useful information from a PET scan to the brain? Maybe Dr. Tumala can answer us, please. Or even Dr. O'Brien as well.
Hi, this is Dr. O'Brien. I don't think that it's that useful. I think that sometimes the PET scan does pick up something that may be suggestive of a brain met, but it doesn't have the level of acuity that an MRI would, and especially for the smaller mets, I think we could miss them.
Okay, Dr. Balduto, how often do you order an MRI for a patient beyond the PET scan for your oncological patients without symptomatic neurological disease?
Actually, for lung cancer patients and melanoma patients, where the incidence is very high, I usually order for all my patients, especially if they have a stage 4 or 3 disease. I think we can find sometimes brain mets in PET scan, but we cannot fully trust in PET scan to search for brain mets, especially the smallest ones.
It does not show asymptomatic leptomeningeal disease.
Yes.
Okay, good, thank you. So this is the patient scan that we're going to discuss. He presented 10 lesions, and some of them as supra and infratentorial, one at the brainstem, and maybe a larger one at the hippocampus, and some of them causing edema. Before discussing what is supposed to do for this patient, we used to stratify a metastatic brain disease to stratify this patient using some scores. And I'd like to ask Dr. Guia, which of these one are you routine use for your patients, like recursive partitioning analysis, RPA, score index for radiosurgery, or JPA specific, or do not apply any one, or even for this case or any other one? What do you guys think? And
yeah, thanks, Marcos. So, we would discuss this, as Dr. Lang has pointed out, in a multidisciplinary fashion, the case, whether it be in the multidisciplinary clinic or in our weekly multidisciplinary tumor board. And we look at factors that are used in these various tools. We don't formally specifically grade them on a case-by-case basis, but we do look at a lot of the factors to try to assess prognosis. We look at whether patients have reasonable systemic options moving forward. We try to get a sense for what their overall prognosis is, and that'll help direct whether we believe that SRS is an appropriate tool for a patient with radio-resistant disease like this, despite the fact that the patient has 10 brain metastases.
No. That's we just had an interesting result. Most of them going for GPA specific, but we have all options applied. Dr. Hanna, how do you manage to stratify these patients, or do you change your management based on your score? I mean, if you use GPA specific or RPA, depending on the score, you can suggest whole brain radiation or radiosurgery for your patient.
Buenas tardes para todos ustedes. Good afternoon for everyone. It's an honor to me to take a part in this group to discuss this case with some of my friends and some of our famous colleagues around the world. I think there is a validation of the DPI specific for melanoma patients, including the BRAF mutation for better patient selection. So I would take this case using the GPI specific, as the majority of the audience has responded the question. And I think we cannot change the indications based only on the histology nowadays. So I would consider for these patients, I think that this will be discussed later on, but I would consider radiosurgery plus or minus surgery for these patients.
Okay. And we just mentioned one important marker, it's a drive mutation. For this conventional, so do you guys, probably Dr. Hussein, look for beyond the conventional pathology, trying to find some drive mutation and then define the best brain treatment for your patient, or we are still looking for size, location, and number of brain mets to define the best treatment option? What do you think, Dr. Hussein?
Yes, thank you. Yeah, no, we are still very early in the molecular era, I would say. The only biomarker of response that we have at hand is the BRAF mutation, and that's a very important marker because we have some effective therapies. And as I had shown early on, BRAF and MEK inhibitors have activity intracranially, so that's the only mutation that matters at this point. We don't hold any further therapy based on further molecular analyses. And, there are some trials here in the US being led by, people like Priscilla Brastianos and Dr. O'Brien is participating in that, where the intracranial lesion is further analyzed for other molecular drivers. And then those patients are treated with specific therapy based on the molecular driver. But that's still very investigational. In fact, one of the problems with that study is that it's single agent targeted therapy, which I don't think is going to be good enough in general for our patients. So for standard clinical care, we don't look for anything beyond BRAF.
And Dr. Baldotto, do you think we should put up front these drive mutations, then the traditional surgery and or radiotherapy for brain lesions? I mean, so if you have these drive mutations, we should start treatment with some targeting drug before the traditional local treatments?
Nowadays, it depends on the type of tumor you're treating. When it concerns to melanoma, it's still a debate in the field. Maybe you can start with immunotherapy for these patients because it's a high response rate in the brain. It's different from lung cancer, where when you have a driver mutation, the first choice is always usually is a driver. It's a TKI. But regarding your question, if I have a very large lesion with edema and symptomatic lesion, of course you can consider surgery up front, even if you're going to use a very active drug. And if you're thinking about radiosurgery, nowadays I'm not so worried about timing because it's a very fast and non-toxic treatment. So sometimes I prescribe, I ask my patients to see the radio-oncologist, and then I start the treatment for the driver mutation. So it's becoming easier to treat this in a multidisciplinary way with the drugs we have nowadays.
Good.
I agree, and I guess the one question that's very relevant for this patient is the symptoms and the need for steroids. I think those are kind of the two main considerations for what to do with systemic therapy.
Okay. Excellent. Dr. O'Brien, do you think CSF study is required for these multiple supra and infratentorial brain mets in a case like this? And do you think nowadays, is there a rule for liquid biopsy, even at the serum or the CSF, that can help you to define maybe these markers and that could change your treatment strategy?
Yeah, so I don't think that there's a role for CSF for all patients with multiple brain mets, but for instance, with a patient who may be at a bit of higher risk for leptomeningeal dissemination, say a patient with triple negative breast cancer who has mets, a large volume in the posterior fossa that appear to be near the surface or the ventricles. I think those patients you might consider CSF, because it is it's minimally invasive, but it's still a procedure with some risk that the patient has to undergo, namely an LP, if we're going to sample their CSF. But I do think that for patients that we are sampling the CSF, it's a really nice opportunity to learn more about what's happening in that space. And liquid biopsy, even if it's still in the research setting, it's nice to be able to bank a fluid for that purpose. Most of the tests that are done in the CSF aren't validated, but it is a wealth of knowledge that we're building on. And in terms of where you say serum versus CSF, generally speaking, we found the CSF to be more relevant than the serum when we're talking about CNS disease.
Good, thank you. And before discussing this case specifically, I wonder if Fred is still there, but how many lesions could be treated with surgery? Is there a magic number? I mean, only the large ones, or you can try to reach 2, 3, 4, or as much as you can in a safe manner. Is Fred still there?
Yep, I'm here. Thank you. I appreciate the question. So the original paper that was published from MD Anderson had a very important point about surgery, and that was that the patients with multiple brain metastases did as well as the patients with single brain metastases, so long as you removed all the lesions. So that's the critical thing. That concept has been translated as so long as you can treat all the lesions, typically with stereotactic radiosurgery. So the number of lesions that are in the brain is really limited by where they're located and how you're going to resect them. So if you have lesions that are near each other, if they're 3 or 4, you can take them all. If one's on the left side of the brain, one's on the right side of the brain, one is in the thalamus, then obviously you can't take them all out. So I think in multiple brain metastases, the driving consideration is any one of those lesions causing significant mass effect or significant symptoms that if you removed would improve the patient's symptoms? Because ultimately the patient's outcome is dictated by the large number of lesions within their brain and whether you can actually treat all of those lesions effectively. So I don't think there's a magic number, but in general, once you get more than 4 lesions, surgical resection becomes less, and we become less enthusiastic about surgical resection unless there's one predominant large lesion that will need to be addressed.
Okay, good, thank you. And moving to the radiotherapy field, Dr. Guia, do you have how many multiple mets could be treated in one section of treatment using VMET or whatever, one of your strategy? Do you think, is there a magic number or as much as you can, considering your safe planning?
Yeah, thanks, Marcos. Yeah, I don't We can treat many mets. We can treat many mets in a single session with SRS, whether we're using Gamma Knife or a linear accelerator-based approach, especially as the technologies advance. It's really a question of whether we should be and whether it's going to benefit the patient long term, versus doing whole brain radiotherapy or considering other modalities. We have, and as I mentioned in my talk, there is an open intergroup trial enrolling patients with 5 to 15 brain mets, and they're randomized to SRS versus hippocampal avoidance whole brain radiation. So it's not really a limitation of the technology. We can treat many mets. We can treat more than 10 mets in a single session. It's whether it's going to be clinically beneficial for the patient.
Okay, good. Dr. Hanna, do you think that nowadays we are trying to saving the whole brain radiation in our pockets and looking forward for doing radiosurgery as much as we can, delaying whole brain radiation as much as we can too? What do you think, Dr. Hanna?
I think that your thought is similar to the Japanese study when they randomized as many radiosurgery treatment as the patient could receive. I totally agree with Dr. Ghia comments, and I would add that since the seminal PET-CHO studies, we have seen the inclusion of patients with an increasing number of lesions, from PET-CHO study with 1 lesion to Yamamoto studies with 4 to 10 lesions, and even the newest study from 5 to 15 lesions. When we take the modern radiosurgery techniques, it's possible for us to protect the healthy brain equally in a patient, for example, with a 150 cc lesion, equally as in one patient with 10 lesions with 5 cc. I mean, technically it's possible to spare the brain with radiosurgery. So the $1 million question is how to select those patients. This is difficult. I mean, melanoma patients will die from non-CNS progression, and they will die equally from CNS progression, regardless of the treatment that the patient has received. So it's difficult to select the patient. I think there is space for discussion even in the 21st century, because I think in the future, when we see a patient with 50 lesion or even 100 lesion, well, we will treat this patient with whole brain radiation. We will spare the hypercampy in these patients. It's difficult. So I think this is not defining the number of the lesions.
Okay, good, thank you. Dr. Ghia, one last question regarding this issue. Do you believe that considering that this patient might receive adjunct treatment, especially maybe immunotherapy, that if you treat the larger ones, the abscopal effect really exists? This is like a mystery for us, but if you treat the large ones, maybe the smaller ones can respond better, combining with targeting or immunotherapy?
Yeah, I think there's anecdotal evidence that you can see that type of effect. If we have a patient set up for stereotactic radiosurgery with a head frame, for instance, we typically favor, my bias is to treat all the lesions that we can see. If we've committed a patient to that, we don't leave lesions untreated in that scenario. But certainly there can be an impact of these systemic treatments on microscopic diseases within the brain. But regarding abscopal, it's at this point, I think a lot of it's anecdotal. It's hard to predict which patients might demonstrate that type of effect.
Okay, good, thank you. So for this patient, for this special case, with 10 lesions, super and infratentorial ones, some of them with some kind of edema, do you think the best treatment option is whole brain radiation followed or not for radiosurgery, chemotherapy, target therapy, or other like removing surgically the large ones and complete the treatment with another strategy. The other is surgery for the large ones, followed by some kind of treatment. Let's see.
So,
People want to vote. And Fred, do you think is there any room for surgery in a case like this?
yeah, I mean, looking at this, there's only one lesion that may be approaching the size. I don't know what the actual diameter is. It looks to me like it's around 2 centimeters in the right hippocampus there.
Exactly.
I don't think I would it does have some edema around it. I don't think I would operate on that. It doesn't strike me that that's causing symptoms or any difficulty. I'm not sure why you told us he had a left hemiplegia and a seizure. I didn't see the lesion that caused that and how big that was. If that might be a lesion to take out, but it looked to me like that was not a large lesion, and I didn't have so I think that
there was a small one with some supplementary motor area edema, but it's a small one, but with some kind of edema.
Yeah, my preference here would probably be to treat all of these with stereotactic radiosurgery and follow the patient. If we could get away with no steroids on this patient, immunotherapy up front might be a good option. And then follow very carefully. And if any of the lesions keep growing, then you hit them with the radiosurgery. Or if you have to do surgery, you can certainly do that. It doesn't have a BRAF mutation, right? You said it has
its behalf is non-mutated.
Yeah, that if it had that would be another option that I would probably go for as a first line.
I agree with Fred. I mean, I didn't answer this question because I don't think the correct answer was on there, which is probably
for others.
Yeah, I completely agree. I mean, the need for steroids is really going to clinch this one. If the patient does not need steroids, you can immediately give them ipi-nivo and expect a response. Sometimes if you're really concerned, you can repeat the scan after even the first dose. As I presented earlier today, we saw the median time to response was after the second dose. So you get, 6 weeks. A lot of the times in our multidisciplinary discussions with the surgeons and the radiation oncologists, the idea that you can wait, 3 to 6 weeks is really what drives whether we can try immunotherapy or not.
Okay, great. So let's keep moving. So we decided to do surgery for the edematous lesions, and by using 2 craniotomies, we removed 6, and followed by whole brain radiation, and then started immunotherapy. And this whole brain radiation, this was in 2017, and for surgical cavities, 10 lesions, maybe more small lesions that we couldn't see at the MRI, we decided to do whole brain radiation for this melanoma. And I would like to ask Dr. Tumala if steroids for immunocandidates are a real villain. So all patients should be taper off any kind of steroids to start it. And this is really important for us neurosurgeons and people that deal with neuro-oncology field, especially neurosurgeons. We consider decadron and steroids as our best friends in our daily practice. For radio-oncologists as well, so any kind of symptom is okay, let's raise steroids dose. So can we consider a real villain for immunotherapy, Dr. Tumala?
I will let my colleague, Dr. O'Brien, take a shot at it.
I would say, if I could comment, I don't know if you view a medication that can help a person as a villain. So there, everything that we do in medicine has a positive and a negative. It's like wearing glasses, right? It's good to be able to see, but they're a little annoying to have to wear. So I think steroids, if you need them, are very effective. If there is an alternative strategy that we could develop, that would be good. So one alternative is sometimes to use Avastin at low dose. We have not really moved in that direction, but for some of our other things like our oncolytic virus therapies, where we really don't want the steroids, we've sometimes used that. So I think if we could develop agents that are other agents that block edema without other than steroids, that would be a real boon to the field. But I don't know if we ever view him as a villain. I think we just have to balance with everything, the positives, the good side and the bad side of any therapy, and go from there.
Okay, so and can we consider, Fred, that maybe we should, when you decide for surgery, using size of lesion, location, and KPS, can we put is this patient immunocandidated, and maybe we're going to operate it just to take it off as chronic use of steroids?
Yeah, I mean, I think that's increasingly becoming a consideration as we now have more data about the effectiveness of immunotherapy, right? So your strategy of taking out the edematous ones, I think that's a reasonable strategy. The problem in this case is the patient has 10 metastases. So, they're still in a very bad prognostic group, and their real outcome is determined by whether they keep throwing more metastases to the brain. So if in 3 months they have now 20 metastases, you've actually delayed a treatment with surgical intervention. So in many ways, I think the reason I wouldn't necessarily jump into surgery right away is to give the patient a chance to see how they're evolving. If they're just continuously throwing metastases to the brain, they're less likely to do well in the long run. If they don't have that, and that is dependent upon the primary disease. So if you can control the primary disease, again, with immunotherapy, targeted therapy, then you have more of a chance to control the brain. And so I would try to delay doing such an aggressive intervention in a patient with 10 metastases. But that's a philosophy right now that could evolve with time.
Okay, good, thank you.
Hold on, can I ask a question for Dr. Hussein, taking advantage of these questions? Dr. Hussein, do you think there's a place for Avastin as a steroid-sparing strategy for patients that would like to start immunotherapy and spare them initially from radiotherapy? Do you think there's a place for that? I still don't understand why Avastin is not oftenly used like this.
I completely agree. I think we underuse it, and there's not enough, kind of trials in that space. I tell you, I think the main reason it's not being used is because Genentech is done with Avastin. They don't want anything to do with it and not to fund any more trials. But I think it's a really great strategy. The only thing I really worry about when we decide to use it is its potential impact on hemorrhage, and again, if the patient needs surgery. So if you're actually trying to decrease the edema because the patient may need surgery, then Avastin may be shooting yourself in the foot. So it's a very difficult decision to make upfront. But I completely agree with you and with Fred in that, I personally say kind of philosophically that as long as we continue to use steroids to decrease edema and suppress the immune system, we still don't know what the immune system is doing, right? Like if we need to learn how to do this without suppressing T cells. And I think the VEGF inhibition is probably one way to get there.
We used to have glycerol in the past, but we don't have it anymore. Tocilizumab is a good option, I think, in some patients. We've seen it used for other reasons and the edema coming down, but it is something that we probably can have to investigate.
Great.
Good. I just, pointed this question, but I think that we're going to move forward. So considering that this patient decided for CNS surgery followed by whole brain radiation and then started immunotherapy, the best immunotherapy option for a patient like this is monotherapy or combined therapy. Dr. Baldotto, would you like to comment on it?
I would go for combined therapy, Ipi/Nivo. We have solid data from a phase 2 trial, besides the other trials that looked into brain mets in melanoma, where we have the same amount of response rate that we got for systemic disease. So especially for patients with melanoma brain mets we go for combined therapy, of course, if the patient has a good performance and can tolerate immunotherapy.
Is there any room for monotherapy, Dr. Hussein, or combined therapy is definitely the best one, and we should start it with a combination of this treatment?
Yeah, I really think that the individuals, the single agent has more limited activity compared intracranially compared to extracranially. We're trying to really understand the addition of IPI, but it seems to be the critical element to get you there, to get you to that really good outcome, that to have IPI. And it should be noted that we do recommend the IPI-3 NIVO1, because obviously in lung and renal cell, it's more common to use IPI-1 and NIVO3. For melanoma, you really have to use the IPI-3 NIVO, the IPI-3 NIVO1.
Yeah. And the other point, I had a patient for an example that she had a resection, the brain met resected. She had no disease, brain disease at the time. She was an old later. So an old later, I decided to go for monotherapy because I was worried about toxicity. And I did not need at that time a good response rate in the brain. But it would be the only exception I would mention here.
Yeah, and I've seen some patients who, not ones that I would recommend, but they would come here either with having started single agent, but with SRS. And I think if you do SRS to everything and you add a PD-1, that may be okay, but that would be a strategy I would do only if there's a really good reason not to do a PNIVO.
Is there any rule to sequence this patient, or even to do immunohistochemistry for the brain lesion, trying to find that this PD-1 alteration, expression?
So in melanoma anyway, whether in the brain or not, PD-L1 is not a very useful marker anyway. In our Checkmate 204, we actually did analyze by PD-L1, and patients that were PD-L1 positive had a better response. But I think it's really interesting that we did the IHC on extracranial tumor, right? We never had intracranial tumor. And the extracranial PD-L1 actually predicted for a higher intracranial response rate. But beyond that kind of interesting observation, I don't use that parameter at all. It's still going to be the number, size of lesions, need for steroids and symptoms, and then whether the patient's capable of handling a PNIVO or not.
And Dr. O'Brien, for leptomeningeal disease, the combination is the best, the combination of immunotherapy for CTLA-4 and PD-1 anti-medication is the best treatment option when you decided, and can we expect a good response for leptomeningeal disease as well as for isolated brain lesions compared to isolated brain lesions?
I think it's too early to say whether it's better in combination or monotherapy, or even really how effective it is in leptomeningeal metastasis. I think it's probably best to base that under what the protocol would be for the underlying systemic disease and go with that. And keeping in mind that these patients may be a bit more prone to side effects as well.
Okay, good, thank you. So the patient received the combination treatment after 2 years. The PET scan and the MRI show absolutely no evidence of disease. And he was with a KPS of 100 and a nano 0. Dr. Battistella, do you think the nano, the neurological assessment in neuro-oncology is a good clinical assessment for this patient, or it's too early to include nano as a routine to all patients with brain mets as we are trying to do for gliomas?
I think nano should be more used nowadays. It's a good way to pass on clinical information and to try to establish a start point in your physical exam. Of course, it does not substitute a complete neurological exam. Maybe your full neurological exam can show you more things, but I do think that by now nano is quite well validated for primary brain tumors, not all validated for brain metastasis, but yes, I think that's a good thing that we can start using.
Yeah, I think I'll add to that. I think the benefit is that it was intended to be a standardized exam for the that a non-neurologist would feel comfortable with. So I think there's that. It's as you said, not complete, but there's that component to it. And then it's something that's standardized and that we can follow over time, that we can follow longitudinally. And I think in the trial setting, that's helpful. And in the LMD space, we're working to try to tweak Nano a bit so that it's a bit applicable. And it is part of that RANO LM criteria for response.
Okay, great, thank you. So this is the scan just highlighting that there is no evidence of brain disease so far. And another issue, for how long this patient should be treated? We just had this brilliant presentation of complications of immunotherapy. So for how long patients should receive immunotherapy, and if we can expect any kind of delayed control when we just stop treatment?
So I could answer that. I mean, we stop treatment early pretty regularly based on the response. And I think the data that was just presented for the 6.5 years update from Checkmate 067, where patients that had a response had an 80% overall survival at 6 years, is very impressive. So depending on tolerability, toxicity, and response, we regularly stop in less than 2 years, sometimes in 6 months. And as you know, the median number of doses for IPI and NIVO is 3. So sometimes we stop very early on. And if it's a very solid response, people maintain it.
And are you seeing a sustained response after stopping treatment?
Yes, we're going to be reporting the 3-year data from Checkmate 204 at ESMO, and it looks just as good as the data before. It's the responses are more than 87% maintained. So, yeah.
Great.
Marcos?
Marcus?
Yes. Mm-hmm. Yes.
I think we have to call it. This is a fantastic case and a fantastic discussion. And I'm sorry we have to end it, but we're past our time, and really appreciate this discussion. Dr. Valdivia, you want to close us out? Thank you.
Realmente, desgraciadamente me tocó cerrar a mí por un tema de limitación con la plataforma, la traducción, etcétera, etcétera. Estábamos muy entretenidos en esta interesantísima presentación. Muchas gracias al doctor Maldaún, a todo el grupo de Brasil. No deja de ser interesante poder armar una sesión para discutir, analizar casos clínicos, revisar un tema multidisciplinario como puede ser el manejo de las metástasis entre Houston, Santiago de Chile, Brasil, aprovechando esta tecnología. Yo solo agradecerle a todos ustedes la participación, pedirle disculpas, Marcos, por haberlo interrumpido al final, pero los quiero invitar a la última sesión que tenemos y invitar a hacer redes, a tratar de alguna forma aprovechar la tecnología dentro de estas pocas cosas buenas de lo malo de la pandemia que ha significado, que es poder juntarnos, reunirnos y aprovechar tecnología. Muchas gracias y les deseo a todos un buen fin de semana.